Thanks, Chairman. It's my great honor to talk to you in this beautiful city. This is my third time visiting Chaosium. Whenever I visited Chaosium, I always had a great time. Today I will talk about the voiding function of the orthotopic bladder and considerations to improve the function. These are the contents of my presentation today. I will focus on urinary incontinence and retention after neobladder reconstruction. The first contents is the introduction of the neobladder. The orthotopic bladder is the main trend in urinary diversion surgery for the last 20 years. Although it depends on surgeon's preference, most of the urologists try to make orthotopic neobladder rather than ileal conduit if it is possible, not only for the male patients, but also for the female patients. These are the three basic principles to minimize the voiding dysfunction. The patients must have adequate external sphincter function. The neobladder should be reconstructed into a spherical shape, and the neobladder should have enough volume. However, patient's selection might be the most important factor. These are the main contraindications of the neobladder reconstruction. The preoperative voiding function and compliance are also very important factors. The initial report about the orthotopic bladder seems very reasonable, not only in the mortality rate, but also in the voiding function. However, the recent report shows that some patients are still suffering from the voiding dysfunction, such as urinary incontinence or retention. The incidence of the voiding dysfunction is not rare. It is up to 50% in female patients. The next contents is the considerations to improving the urinary incontinence. Daytime continence develops gradually over 3 to 6 months. Persistent nocturnal incontinence is more common, and it may continue beyond 12 months after surgery. During the operation, it is very important to preserve pudendal nerve, and also to avoid deep suture bites into the pelvic floor muscle. Nighttime incontinence is the most bothersome sequelae after neobladder. It is not easy to improving the symptom, because it can be caused by various pathophysiology. Behavioral therapy, such as nighttime alarm, can be tried. Transurethral collagen injection had been tried to improve incontinence, but it is not so acceptable for a long time. Although injection of urethral bulking agents is a minimally invasive treatment for stress urinary incontinence, however, the long-term results, especially in patients with severe incontinence, show a less than optimal durable response. There were some case reports about the pubo-vaginal sling trials. The results was somewhat horrible. A patient need cutaneous diversion. Others died because of the bowl injury. The others become complete dry. But they also need CIC for the urination. Although there is not enough articles about the artificial urethral sphincter, it might be the treatment of choice in my opinion, because it showed very acceptable result for the incontinence following radical prostatectomy. Moreover, dual prosthesis, including penile prosthesis, has been tried recently. Next content is about the urinary retention. The incidence of the chronic retention seems to be more popular than urinary incontinence after neobladder reconstruction. The chronic retention can be caused by structural problem, such as acute angulation or herniation. Medical treatment may not be effective for these cases. During the operation, back support augmentation using round ligaments or omental flap may prevent the problem. The urinary retention can be cured by the obstructive procedure. According to an article, about 10% of the neobladder patients needed this procedure. There are various causes of urinary retention after neobladder surgery. It can be caused by shape of the neck of the neobladder or urethral stricture. In some cases, mucosal prolapse or tissue regrowth can induce urinary retention. The patients who had a funnel shaped out may have urinary retention because of the kinking and mechanical obstruction. A revisional surgery is required to reconstruct the neovesico-urethral anastomosis for these cases. Mucosal prolapse may induce the retention. Transurethral resection may be needed. Sometimes, prostatic enlargement from the remnant prostate causes retention. It may also need transurethral resection. Although it is reported 12 years ago, this article shows very interesting data. About 6% of the patients had eventual emptying failure 10 years after neobladder operation. The patients without mechanical obstruction tend to remain eventual voiding failure, and all of them had no specific reason for the retention. I am very sorry to saying that the voiding function after neobladder operation is not easy thing, as we experienced. Anyway, let me conclude take-home messages. Daytime incontinence improves gradually over 3 to 6 months after operation. During the operation, it is very important to preserve pudendal nerve and proximal urethra, including rhabdosphincter. Persistent nocturnal incontinence more common, and it may improve as late as 24 months. The artificial urinary sphincter seems to be hopeful compared to the bulking agent injection or pubovaginal slings. The urinary retention has been reported in 4% to 25% of patients and tends to be more common in females. Almost all male patients should initially achieve spontaneous voiding, provided that a funnel-shaped outlet is avoided. Voiding failure may occur at any point during long-term follow-up, may be encountered by an average of 1 to 2 in every 10 men. Appropriate obstructive surgery may be effective. Functional outlet obstruction from a non-relaxing pelvic floor is rare. Almost all of the patients with dysfunctional voiding will have to receive CIC until the mechanisms of dysfunctional voiding are fully understood. I have good friendship with Taiwan urologists more than 13 years. I hope our friendship may continue to the next generation and let them feel happiness just like us.
感谢您的时间和关注。